Hello again, doctors, and welcome back to my channel. In this series on high-yield neuro, we're going to be going through MR images of the brain in all different planes in order to identify major structures and go over some high-yield topics. So without further ado, grab some coffee, get comfortable, and let's get started. And to do this, we're going to use a website that has an interactive module. It's a full MRI in all axes, starting with axial or transverse sections, which are on the left. These are the most high yield because these slices will show the most number of structures. These are the ones we're going to be focusing on today, and I'll cover the rest in further modules. For reference, in the middle we have sagittal sections, which for the purpose of this video will stay the same. And on the far right we have coronal sections, which are not that high yield, but I'm going to be using the coronal plane to affix our height on a superior-inferior axis. And you can always tell where the axial section is taken from by following the red line across. If we consider the brain as a whole, neuroanatomy can seem kind of overwhelming, so we're going to simplify it down to smaller parts, and hopefully you'll see that there's sort of this triad of location, structure, and function. First, if you consider the cerebrum or telencephalon, the actual brain tissue, organized into sulci and gyri, and on a larger scale, organized into lobes, which each carry out their own executive functions. Aside from that, on imaging, it all looks the exact same. It's easily discernible from the structures beneath. So if we peel away that layer, the deep nuclei and lateral ventricles are revealed, and as you can see, are mostly midline. So that's the first trick. On any axial section, always have your eyes go straight to the midline to see what structures are present or not. And in terms of landmarks, the most superior midline structures would be the right and left bodies of the lateral ventricles, and the right and left bodies of corpus callosum, which is not shown on this model. So using those two specifically as landmarks, we're going to split the brain up into three parts. Those slices above the body of corpus callosum, those slices within the area of the body and the inferior aspect of the splenium of corpus callosum, which would include the basal ganglia, lateral ventricles, thalamus, and third ventricle. And those areas below it, which may include the inferior aspects of the thalamus, the hypothalamus, but mostly the brainstem, midbrain pons, and medulla, including the cerebellum. Using those two as landmarks, we're going to start with those slices above the level of the body of corpus callosum. And remember, we're focusing on the axial slices, keeping our eyes on the midline, then moving laterally. So starting from the top, as you start to see more tissue, you see the longitudinal fissure, which divides the two hemispheres of the brain. But in terms of structures, all that's at this level are the cerebrum and skull. You see no midline structures. The corpus callosum and lateral ventricles aren't visible at this level, only cerebrum, namely the frontal and parietal lobes. We're too high up to see the occipital or temporal lobes. You can see the central sulcus marking the boundary between the frontal and parietal lobes, bordered by the pre- and post-central gyri. The precentral gyrus is your primary motor cortex, so corticospinal and corticobulbar. Voluntary motor tracts to the body, neck, and face, respectively. Motor is a descending primary efferent tract, so in other words, it's the start point of your motor pathway, and that large bundle of axons is just heading downwards towards the face and body. And then the post-central gyrus is the primary somatosensory cortex, and this is the end point of your general sensory tracts. So the dorsal column medial lemniscus for basic touch, vibration, and proprioception, and then the anterolateral or spinal thalamic tract for pain and deep pressure. These are ascending afferent tracts, so kind of the opposite of motor, and usually these are tertiary neurons coming from the body, carrying that sensory information to their nuclei, the thalamus, and then ultimately the somatosensory cortex. So other than being able to identify the central sulcus at most, that's all there is to see at this level. And this all holds true all the way to our main landmark, the body of corpus callosum. And you can see we're still above the bodies of the lateral ventricles, so it makes sense that we don't see anything. So really, we don't need to know what every slice looks like, as long as you're able to pinpoint the fact that you're superior to the body of corpus callosum and the lateral ventricles. So this is our first high-yield slice that we need to know for clinical questions on STEP. At this level, the highest yield pathologies are the hematomas. Subdural hematomas mainly occur in the extremes of age, so babies and the elderly. It's a classic sign of shaken baby syndrome in children under 3, especially under 6 months, due to their weak neck muscles and unfused skull bones making them more vulnerable. If violently shaken, the injury is contractile as the baby's heavy head is thrown backward and the brain bounces forward on impact. In the elderly, there's a natural brain atrophy that happens as we age, so the brain just shrinks, leaving bridging cortical veins vulnerable to shear stress, even with minor impact. The blood will spill between meningeal dura and arachnoid mater, and the CT or MRI as seen will show a crescent moon or banana-shaped bleed along the lateral surface. Babies can present with extreme irritability, bluish tint to their skin, or vomiting, although the symptoms may be subtle depending on how severe the shaking was. Whereas in the elderly, bleeds can occur with even minor traumas or falls. Even smaller impacts can cause slow bleeds, meaning that they can present with either acute or subacute onset headache and confusion. In all cases, regardless of age, the shared progression and complications are paralysis, focal or global, loss of consciousness, and ultimately coma if treatment is not sought. Epidural hematomas are different even on presentation. It's a more traumatic head injury, usually a lateral blow to the side of the head. Blood, typically from the middle meningeal artery, fills between the periosteal dura and the skull, tearing the two apart. Remember, the skull has 2 layers of dura, unlike the spinal cord. If you were to hold the 2 layers in the skull in your hand, they're so tightly adhered to each other and the skull, it would be impossible to pull them apart manually. So the pain and pressure created by an epidural hematoma is profound and requires immediate evacuation to release pressure. Along with the acute onset headache, the patient will experience the lucid interval, being initially conscious post-trauma, but ultimately losing consciousness. And the CT or MRI will show a biconcave or football-shaped bleed that does not cross suture lines. And that's it for our first axial section and its correlates. Now we're going to move inferiorly to the sections below in the area of the basal ganglia and diencephalon, or thalamus. Starting off with the most superior medial structures, the lateral ventricles, which are located just below the body of corpus callosum. So if I move just below the body, you can see that the bodies of the right and left lateral ventricle become visible. And as I continue down, the full image of the ventricles and surrounding structures appear, and they're best seen at about the level of the fornix, which wraps around the thalamus. In terms of axial images, this area is the most high yield because there's so many structures that they can test you on. So let's start from the midline, using the lateral ventricles as an easy landmark to determine what level we're at. As you can see, they're curved C-shaped structures that span a pretty large area of the cranium. At the level that we're at, we slice through 2 portions, the frontal horns and the 2 trigones, or atria, which are the more superior aspects of the total system. As you can see, the frontal horns end just below this level and won't be seen on imaging. So if that typical butterfly shape is seen, the image must have been taken from this level or near it, because it's cutting through those 2 superior aspects, the frontal horns and the trigone, which the frontal horns are not found at the level below. For reference, once below the frontal horns, in the area of the true thalamus, you obviously won't see the horns, but what you do see are the third ventricle and the occipital horns of the lateral ventricle, which are in the inferior aspects. So the trend is, once you're past the body of the ventricles, the further down you go, you see less and less of the ventricles. So look for that butterfly shape. Another notable feature here is this band of white matter, which is sort of shaped like a boomerang, called the internal capsule, which is surrounded by the basal ganglia and thalamus. The basal ganglia are referred to as the deep nuclei, and they have many roles. But in terms of testability as well as relevancy to clinical practice, their number 1 role is in regulation of voluntary muscle movement. The internal capsule, which is actually not a capsule at all, but a large bundle of white matter, it's made up of the anterior and posterior limb with what's called the genu in the middle. The genu and posterior limb are the most important to know because they're a continuation of the corticobulbar and corticospinal tracts in the somatotope scene, which is in clinical orientation, so it's actually already shown inverted as seen on imaging. The genu carries fibers from the corticobulbar tract to the face, and the posterior limb carries corticospinal fibers to the body. So the same voluntary muscle movement we spoke about coming from the precentral gyrus then goes on to form the genu and posterior limb, with the fibers passing through the basal ganglia, with the caudate nucleus and thalamus bordering medially, and the globus pallidus and putamen laterally. In terms of function, as I said, the basal ganglia are in charge of regulating voluntary movement, so it makes sense that the fibers of our motor tracts pass through the regulatory center before continuing on. Let's review the structures of the basal ganglia and see how that translates onto axial image. Starting with those structures lateral to the internal capsule, first is the putamen, which is the largest of the lateral nuclei. Moving medially, we see globus pallidus lateral and medial, or externa and interna. These lateral structures, the putamen and globus pallidi, collectively are called the lentiform nuclei, and they're all sort of shaped like discs, and they look similar on imaging. The medial basal ganglia structure is the caudate nucleus, which is found next to the lateral ventricles and follows their same curvature. The thalamus lies inferior to the basal ganglia and again medial to the posterior limb of the internal capsule. Let's see how this all translates on imaging. Again, first we notice the butterfly shape of the lateral ventricles along the midline, marking our location. Remember, the C-shaped structure next to the lateral ventricles is the caudate nuclei, namely the head of the caudate bordering the anterior limb and the body and tail bordering the posterior limb. The other medial structure, the thalamus, is this pink circle here, again medial to the posterior limb. Lateral to the capsule, we have the lentiform nuclei, the putamen and globus pallidi. To keep those in order, I have this trick. You can think of the internal capsule as being shaped like an alligator mouth, and moving from lateral to medial, he puts globs into his mouth. So globus pallidus is medial to the putamen going into the mouth. And that's it for our midline structures. Let's move on to the lobes. Actually, at this level, all 4 lobes can be seen, with the frontal lobe anteriorly, parietal and temporal lobes laterally, and the occipital lobe posteriorly. To recap, we start off in the midline with the thalamus and caudate nuclei, medial to the internal capsule's anterior limb, genu, and posterior limb, with the genu and posterior limb carrying our voluntary motor tracts. Then laterally, we have the lentiform nuclei, globus pallidus, interna and externa, and the putamen. We have collectively the basal ganglia and thalamus playing their roles in regulating voluntary muscle movement. And finally, for completion's sake, the parts of corpus callosum seen are the splenium posteriorly and the rostrum anteriorly. For the high-yield correlates, we start off with the vascular lesions. Aside from the hematomas, which we've covered already, there are strokes and infarctions, which can be hemorrhagic or ischemic. A lesion of the posterior limb of the internal capsule is a favorite, like the one seen here, where the right posterior limb is implicated. For the most part, the entire internal capsule is supplied by branches of the middle cerebral artery called lenticulostriate arteries, and depending on the size and type of the lesion, can result in a range of symptoms from weakness and upper motor neuron signs to paralysis of the opposite or contralateral side, commonly in the upper and lower extremities. And facial paralysis is possible if the genu is implicated. For reference, the middle cerebral artery does go on to supply most of the lateral surface of the brain, and this includes the motor cortex from earlier, however only on the lateral surface. As you can see, the homunculus starts at the feet along the medial surface, and the hips bend over the lateral surface for the torso, arm, and the thumb points to the top of the head, and that would be the start of the bulbar tract. The entire motor cortex has 2 blood supplies, with the medial surface being supplied by the anterior cerebral and the lateral surface by the middle cerebral artery. Not only will lesions in this area be more focal, for example, only left hand weakness or only left hip weakness, but the difference in blood supply make upper and lower extremity pathologies highly unlikely, whereas in the internal capsule infarctions, they typically involve the entire contralateral body. In the case here, the left side of the body. Now, besides the medial structures, infarcts of the different lobes are another possibility. The parietal and temporal lobes carry the superior and inferior optic radiations respectively, and I'll link my video on this in the eye. Because the retina perceives an inverted image, the temporal or inferior radiation carries information from the superior visual field, and infarcts, as such, will result in a superior quadrantinopia. In this example, that's the right inferior radiation, which will cause a left superior quadrantinopia. The parietal lobes carry the superior radiations, and in this example, the left superior radiation, causing a right inferior quadrantinopia. And they share a blood supply from deep branches of the middle cerebral artery. So remember, to distinguish between parietal and temporal areas, look for the butterfly.
Notice how it's visible on the right image for the parietal, but not on the left. Only the third ventricle and posterior horns are seen in the left image. If the occipital lobe is infarcted, that's supplied by the posterior cerebral artery. This is where the entire visual cortex is located, and it's the endpoints of the radiation. So an infarct there, like in this case, of the left occipital lobe, will result in a right homonymous hemianopia with macular sparing. That macular sparing is because the macula has collateral blood supply from its main artery, which is middle cerebral. And since middle cerebral can also supply the radiations, a lesion large enough can cause homonymous hemianopia with no macular sparing. So depending on the size of the lesion, an infarct of middle cerebral can cause a quadrantenopia or a homonymous hemianopia with no macular sparing, whereas an infarct of the posterior cerebral artery will only result in a homonymous hemianopia with macular sparing. And that's it for the vascular pathologies. The rest of the hyocorrelates are degenerative, and they involve the deep nuclei and thalamus. The first is Wilson's disease, a genetic disorder of inappropriate copper metabolism, including excretion. So it builds up in various tissues, namely the liver, kidney, cornea, and brain. It's an advanced disease that the CNS is involved, and the copper is mainly toxic to the putamens and thalami. Huntington's disease is another genetic disorder that's caused by mutation in the gene Huntington, part of which is a trinucleotide repeat. That means it contains a sequence of 3 DNA bases repeated multiple times. In this case, cytosine, adenine, and guanine, or CAG, which is actually the codon for glutamine. So the repeated sequence of CAGs produces a chain called the polyglutamine tract. In a patient with Huntington's disease, they will have an abnormal number of these repeats, which results in a mutated protein causing the disease profile. Neurological symptoms of Wilson's disease will actually mimic Parkinson's, so rigidity, bradykinesia or slowed movement, masked faces, and arresting tremor. Huntington's, on the other hand, has more of a cognitive component, where changes in personality are usually first seen, like impulsivity or aggression. Its inheritance is also autosomal dominant with almost full penetrance, so there's usually a positive family history of disease in the vignette. The characteristic movement in Huntington's is called chorea, which is like a slow writhing movement of the hands or feet, and then it can advance to bullismus, which is a flinging of an extremity. In both cases, you can see the symptoms of basal ganglia pathologies have some component of involuntary movement, like a resting tremor, where you're trying to keep still but can't, or bullismus. The issues are in regulating voluntary movement, which again is the major role of the basal ganglia. This is in contrast to the posterior limb lesions affecting the motor tracts, which cause weakness or paralysis, or sort of the absence of motion. Basal ganglia pathologies cause unintentional or improper movement. The muscles themselves are fine. The motor tracts are intact, but the regulation of movement is affected. And that about wraps it up. So this is the second high-yield axial slice to remember. In terms of the rest of this section, we were at about the level of the fornix. So if we continue down towards that bottom yellow line to round out this section, you see the first new structure that comes into view is the orbit of the eye. So that's another good landmark to use to determine location. This area is that dotted line, mainly through the thalamus or diencephalon. So the frontal horns of the lateral ventricles aren't seen. We can only see the third ventricle, which is through the thalamus, and the posterior horns, or atria, of the lateral ventricles. In terms of structures, they're still visible and they haven't changed location, with the thalamus encoding nuclei midline and the lentiform nuclei laterally, with the internal capsule dividing the two. Now below the diencephalon or thalamus is the mesencephalon, or midbrain. The genu and posterior limb of the internal capsule with our motor tracts go on to form the bulk of the cerebral peduncles, aka crus cerebri of the midbrain, which form its ventral surface. So I'm going to move inferiorly until we see the outline of the midbrain with the cerebral peduncles. And this is the start of the next section, the brainstem, which I will cover in a part 2 video. Just to recap the route that the motor path takes, and we can actually use the coronal section for this. It starts as primary efferent neurons that descend down from the precentral gyrus and form parts of the posterior limb of the internal capsule and genu, and then go on to form the bulk of the cerebral peduncles of the midbrain. Alright, so that's it for the axial sections above the brainstem. Hopefully now you can tell when you're above corpus callosum or below it in the area of the deep nuclei and diencephalon. Remember, always start at the midline and use the lateral ventricle shape or lack thereof to determine what level the image is from. And if you'd like to use the MRI module I was using, go to headneckbrainspine.com, then to Neuroanatomy modules, and choose Brain MRI, clicking on the icon to open it in a new page. The 3D model is the free version of ZygoBody. It's okay for a basic app, but if you're in the market for an app, I'd highly recommend Essential Anatomy. It's worlds better, and it's a one-time purchase.
ZygoBody is lacking a lot of features and should step up their game for the free users because it's only by subscription and it's really expensive, just saying.
Anyway, doctor, that's the end of this video. I hope it was helpful to you, and if it was, hit that like button just down below. Make sure you stay tuned for part 2. Good luck studying, and I, of course, will see you on the next one.
Hold me ever get seen in my life. Girl, me want fi just squeeze you, put me thing right around you.